Hi, we have officially made it to week 8. I apologize, I'm trying to get this done on time, but I'm currently hospitalized, so I'm trying to complete this project the best I can. But we'll just go through my PowerPoint, which I have attached in the Dropbox as well. So we're doing the Implementing Evidence-Based Practice, and I'm going to be focusing on a mobile stroke unit program. The objectives of this is to identify a clinical problem, a critical appraisal of the research that was done on mobile stroke units, outlining a strategic plan for implementing the new practices from the evidence base. We're also going to look at using models to go ahead and change the clinical environment and be able to take care of barriers. We're also going to demonstrate how sources of internal evidence gains data to increase success, and then also identify ethical concerns. So, in the Lancet Neurology article, there was a research study that was done in England. They identified what a mobile stroke unit is. They reviewed what exactly they are and how it's supposed to work in improving lives. And they combined data from different research projects throughout the British Kingdom. There highlights the risk and opportunities used with the mobile stroke unit, and the study was gained from practitioners' experience throughout London in the mobile stroke unit. Their concluding results was that it was very beneficial. In the Clinical Ultrasound Journal, it was a quantitative study that went through the actual color-coded sonograph that's used in the mobile stroke unit. They enrolled 232 stroke patients. 102 of them did get the complete exam, and out of those 102, 73 patients did have a stroke, and 25 were ruled out. Their goal was to go ahead and prove that their scanner on the mobile stroke unit is just as reliable as the hospital ones, and their conclusion was that it did demonstrate high accuracy. And there was a patient qualitative study that was done. They surveyed patients between 2011 and 2012 on how their stroke was handled in pre-hospital in the mobile stroke unit as well as in the hospital. They noted that educating the community on FAST symptoms, facial droop, asymmetry, speech, and time, definitely made a benefit in patient survivability, but also the care that was provided en route showed an increase in survival. They did notice, though, that they needed to work on, once the patient gets into the hospital, how to continue to manage the stroke. We also did a qualitative focus group on why people tend to delay to call for help when they see stroke-like symptoms. The study emphasized thinking patterns during the anxiety of an active stroke, and it definitely brought out more of the awareness of the FAST campaign. Another research article was on the thrombolytics and how they are administered in the mobile stroke unit. They wanted to identify patient outcomes 90 days after thrombolytics. It was a randomized controlled trial, and it was performed in 1991 through 1994. The statistical analysis showed excellent improvement in people getting their thrombolytics in the field and in that golden window. We also did a research one on telemedicine and stroke. Telemedicine is the major component for the mobile stroke unit. That's how the neurologist can communicate with the crew on the unit. They said basically the telemedicine is needed in stroke care and has shown very good possibilities of increasing survivability. They also noticed that it was very reliable for neurological assessments because they were able to do it over video, not telephone, and they said doing it over telephone, a lot of stuff can get missed. So how would I implement the mobile stroke unit? First, I would form a clinical question. Does the treatment in a mobile stroke unit reduce the time to treatment? And when we're talking about treatment, we're talking about thrombolytics. Then I would gather the research and evidence, either through research textbooks, journals, databases, as well as patient surveys, even employee surveys. And then go ahead and do a critical appraisal to figure out which is the best research that has the most validity and the least risk. Then determine patient preference and evaluate the clinician's understanding of how the change process is going to go and why it's going to be beneficial to use the mobile stroke unit. Then using a model, the plan would be implemented into practice. And throughout the process, we want to engage patients as well as staff in the change process as well as identify barriers and work through them as it is getting rolled out. So I use the Ferris mode, the PARIHS mode. It deals with evidence, context, and facilitation. Under evidence, we need to figure out the research that supports the use of the mobile stroke units. We also need to make sure that the staff are competent and able to use the equipment. And we also need to see that those people who are treated on the mobile stroke unit, they were asked if to participate in the data. Under the context thing, we made to able to uphold that there's cultural competence on the unit. Always keep that in mind. Some people have always the right to refuse a medical treatment, especially blood with Jehovah's Witnesses. There also has to be a competent leader that people aren't scared to go to, but also know that they can have their questions asked and not be penalized for it. Also, constant feedback and evaluation on how each dispatch went is important. A debrief after each one can go ahead and mark out things that could have been done better and ways for improvement. And then also evaluate multiple departments and how they're doing in their learning environment and how they're doing the implementation project. Facilitation is, again, making sure that all staff are aware of their role in each part of the mobile dispatch. And if not, there should be continued education, and it should always be provided. If they feel not comfortable, there should always be somewhere they can go right then and there. Annual skill fairs should be completed to ensure continuity of care of the patients. And then we should always educate the patient on what, if they are participating in the study, what their rights are, what their role is during the study, education before and after the project, and then also getting their informed consent. And we also need to remain there's an environment of partnership and not one of a dictatorship. Everybody has a role in the process of rolling this out. Sources of internal evidence could be data that's taken from the mobile stroke unit from the stroke coordinator, like how fast people were getting thrombolytics, how fast the unit was arriving to the patient. We can also look at data of the cost versus the benefit. These units are very expensive to run, so we want to be making sure that we are actually improving times of thrombolytics by using the mobile stroke unit versus using just regular hospital. Basically making sure that there is a benefit to using the stroke unit goes ahead and makes the cost justifiable. We also would use data from quality improvement to determine that the mobile stroke is not only effective in the time that the stroke is called, but that these victims are having as minimal residual effects as possible. We can also take data from the electronic healthcare record that these patients are receiving and make sure that they're getting every single step of the process that is required, such as EKG, blood glucose, scan within minutes of the door, TPA administered as quickly as possible, and keep those trends going and see where the fallouts are and where there needs to be improvement. Ethical considerations that can happen is we also need to determine if doing this project is doing the right thing for the patient. We need to make sure that the project is there's a difference between the clinical research of this project or if it's a evidence-based quality improvement initiative. The difference in those is that when it is a quality improvement initiative, the research has already been done. We're basically rolling this out on the unit and then evaluating that. If it is a clinical research project, we are still gathering the research, and informed consent is required from all participants. And then when we do get participants, we need to make sure that they're fully aware of what their study will be, and they will have the opportunity to decline to be part of the study. Take all attempts possible not to harm the patient, both in transporting the patient and also administering thrombolytics. In the end, we're trying to improve patient care, but we don't want our study to be a hindrance in patient care. Also, we always have to make sure that we have a fair subject selection, so there's not a bias between culture, color of skin, poor or rich. There's a fair selection of individuals. And all studies have to go through a review, and also that has to be accepted before the project can even be started. So when in doubt, is this a research project or a quality-based improvement initiative? Always just go ahead and get an independent review. So my conclusions are there's still a lot of research that needs to be done on the mobile stroke unit, but the stuff that is out there now shows that it is beneficial. We need to make sure that there is a concrete implementation process of evidence-based practice when the mobile stroke is used towards facility. I currently work at a facility where you use a mobile stroke unit, and there are steps that each employee has to use, and they know what their role is, and each person has a voice in the program. Participants will be provided with informed consent of how their information is going to be used, whether we're going to use any part of their medical record, and that does include name, date of birth, or even just the day that occurred and their transport. Celebrating small successes through each milestone will continue to keep the project in momentum and also make people feel like they had a hand in making sure that people are getting the best stroke care that they can get. As always, make sure there's no harm to the patients. Make sure that the study that we are performing or the evidence base that we are putting out there does have some scientific validity behind it. And so far, here in the state of Colorado, and from what I've found through research, the mobile stroke unit has shown a very favorable increase in patient outcomes because they are receiving thrombolytic therapy, usually in the field within 5 to 10 minutes, instead of waiting until they get to the hospital. On the next slide of my PowerPoint, I just included a video of the mobile stroke unit program that is done through the hospital that I currently work at. Thank you so much. Sorry for the rough background and rough me. I tried my best, and I really enjoyed this class. Thank you.